I feel like I'm fixin' to die. It's the Medicare for the Lazy Man podcast. It's a hunka burnin' Medicare podcast. What has he done for you lately? It's Medicare expert Doug Jones.
Hello, everybody. Welcome to another episode of the Medicare for the Lazy Man podcast. You might have heard my Canadian nephew, Drew McMillan, tell you who I was. Just in case you weren't paying attention, let me tell you again, I am Doug Jones, your Medicare expert, and I am here to give you some confidence about your impending encounter with Medicare. Now, you may not have an impending encounter coming up for a few years. It may be that you're working and you're not really contemplating anything until you retire, and that would be the correct attitude. It might also be your 65th birthday is headed down the pike, and you want to be prepared for it. Any of those situations and many others, I can help you through. So what I suggest that you do is buy my book, Medicare for the Lazy Man 2024. You can go to barnesandnoble.com to get the paperback book, or you can go to Amazon.com to also get the paperback for about $9. You can get the Audible book for about, I think, $6 and change. You can get the Kindle version immediately. That's not, you don't even have to wait for that. And that's going to cost you something like $4.70. Or if you want to live high on the hog like I do what I would do and buy the $24 hardcover version. It has colorful illustrations. It is durable and yet beautiful at the same time. So for $24, you can purchase the hardcover version. And when you're finished with that, you can leave it on your coffee table for your visitors to admire and ooh and ah at. But in any event, whichever version you buy, they all have the same Medicare information, and they all have my contact information, so that when you're ready to consider your Medicare options, and when you're ready to look at what the likely costs are going to be, or if you want to hear what I'm going to suggest, as I do for most of my clients, then what you do is you get my contact information, send me an email, I'll send you a questionnaire, or you can go to my website, lovingly created by Randy and his staff, and you can click on I'm ready to sign up for Medicare, and you'll be confronted with a very short questionnaire asking some information about you. Once I have the responses to the questionnaire that you've filled out, I'm able to tell you what all of your Medicare supplement options are, what they're going to cost you, and I'm going to have my recommendations to send back to you. And that's going to be a beautiful thing for you. It'll narrow down your area of expertise, area of concentration, and you will have many fewer choices because you'll be choosing from only the best plans available. So I would suggest, once again, purchasing Medicare for the Lazy Man 2024. And then you can come back and listen to another episode. By the time you've done that, we'll have another episode posted for you. Randy is in charge of that. Randy, are we caught up with our prior episode recordings that we have to post?
We are. I've been busy. I know you can see in the background, I've been very busy. I neglected to tell you that Medicare for the Lazy Man has purchased a new Airbnb.
You know something? McDonald's company started out as a hamburger restaurant somewhere in California. I forget where. And eventually, if you watch that movie about the founder, somebody told Ray Kroc, you're not a hamburger purveyor anymore. You're a real estate magnate. I figured that's the way Medicare for the Lazy Man is going. We have more buildings and property and things like that. This is a magnificent edifice that you're sitting in right now.
It's really pretty. It's really pretty, isn't it?
When did we stop being a Medicare company and start being a real estate acquisition company? How did that happen?
Well, it's been a couple. Well, all right. I got to be honest. we've been dabbling in real estate for a couple of years, but we used to have yachts, and I decided that the yacht business wasn't as profitable because, during COVID,
Uh-huh.
you couldn't get anybody on a yacht for no money.
Well, there were a lot of people that were pretty afraid to do anything during COVID. It hit you and your lovely bride kind of hard. It didn't hit me at all. And so I understand that was a weird time. But how about the airplanes? We had a fleet of airplanes at one time. Whatever
We
happened to
do,
that?
we do. They're still in the, they're still on a private airstrip,
Oh
and
boy.
I mean, you're the chief pilot, so I'm waiting for you to get in the mood that you need to go flying again.
Well, here's the deal. I'm so busy reading the annual reports and purchasing red ink so that you can print more financial reports that I'm not sure that I'm going to have time for any sort of recreational activity like that. But all right. Well, I'm going to see what I can do about getting out there and at least walking around, kicking a few tires and
Well,
checking it.
yeah, there's that. Plus, the other thing you're having to track right now is, the march of the cicadas coming.
Well, I would be more concerned if I could actually see a cicada, but I haven't seen or heard any sign of any cicadas.
Maybe these
Maybe
are the new silent cicadas.
I'm I like I like the idea of the fact that they might have forgotten what what year it is, and maybe they're not coming out this year.
Well, yeah, I mean, as we've talked on previous versions of the podcast, I find it extremely interesting that if cicadas do come in early or they
Yep.
come in late, it's always by a multiple of 4 years.
Okay, I didn't know that. So
Yeah,
I
so
might have 3 years of non-cicada problems
yeah.
then, right?
And
Okay.
the other thing I find interesting, you know how my technical brain works, but there's a 17-year batch.
And a 14-year batch.
And if no, well, no, it's a 13-year batch because there's always
No.
there's always 4 years difference.
Okay,
If
I
you
hadn't heard
they
that.
Yeah, they call the 17-year batch and the 13-year batch because there's 3 4 years apart, and I think you'll find that ultimately the two batches are officially called 17 and 13.
Well, they were last out together, socializing and doing what cicadas do during the presidency of Thomas Jefferson. And
Yeah,
I'm being told that we have to prepare ourselves for another onslaught like occurred back, around 1800.
yeah.
And
I think if I'm not mistaken, they carried off Thomas Jefferson's dog.
well, I don't know if that's true or not, but I know that that's pretty far away. That would have occurred in Virginia, and I'd like to think that no cicada is going to travel to Illinois to carry a dog, which I don't even. So, I,
Yeah, but they've got Uber now.
oh God. Well, they've also got our fleet of airplanes. If they're willing to pay, I say
True.
let's lease them the airplanes.
Yeah, true. I totally get it. So anyway, that's my theory for today. But in my role as the nominal producer, I really feel like we should get to the good stuff, which is Medicare.
That's one thing I always agree on. So let's do our Medicare content curator. I managed to tackle and sit down in a chair, handed her a yellow marker, and we actually have some real content today. And now there's a big red thing on the screen. Shouldn't disturb me at all. So I'm just going to forge right ahead. The first content we have that was curated specifically for our audience today is, of course, a hit piece. No, an expose of Medicare Advantage plans. And why do we keep pounding on Medicare Advantage plans every time we find an article that warns people that Medicare Advantage plans are trouble? And that's because it's my responsibility as a Medicare agent, as a Medicare expert, to warn people about the potential of disappointment that comes with a Medicare Advantage plan. The last episode, or a couple of episodes ago, I tore into a long article that described the fact that many large employers, instead of purchasing health insurance for their retirees as they promised to do, have taken to forcing their retirees to enroll in Medicare Advantage plans if they want to take the company retirement insurance option, because the feds, the tax, will pay the freight for the retired employees. And that has been something that's caused many people to say, well, Medicare Advantage plans are very popular. Look at the growth in that market. But in reality, Medicare Advantage plans have not gained in popularity so much as many large groups of people have been forced to patronize or to become insured by Medicare Advantage plans because their companies have said, this is the only way that we're going to help you with retiree health insurance. We're going to pay the freight, meaning the taxpayers are actually going to pay the freight. And if you want to go into retirement with our insurance that isn't going to cost you much or anything at all, then you've got to take Medicare Advantage plans. So you've got all these groups of people being forced into Medicare Advantage plans. In addition, you have people on the I would say the left side of the political spectrum who have taken up a stand against Medicare Advantage plans because they don't like private enterprise and they don't like companies that are out there to make a buck in the healthcare industry or health insurance industry. I don't agree with those people on almost anything, but I do agree with them in their war against Medicare Advantage plans because, once again, Medicare Advantage plans are likely to disappoint. Now, not everybody that has a Medicare Advantage plan gets disappointed. So what I say in my book is Medicare Advantage plans are just fine for everybody until you get sick, until you need to use the plan. And that's when you may start seeing some very, very disappointing elements of the Medicare Advantage plan that you selected or that you enrolled in. Now, the problem then is if you've had your Medicare Advantage plan for longer than a year, you don't have any recourse. You're going to have to go through medical underwriting in most cases. Not everywhere, but in most cases, you're going to have to go through medical underwriting, and the insurance company whose Medicare supplement plan you prefer to have is perfectly able to refuse to cover you. So Medicare Advantage plans are doing a lot of screwy things in delaying and denying coverage for their clients. And that leads to additional disappointment. So this is my warning to you. And this article is entitled 10 Key Questions That Are Facing Medicare Advantage Plans. There's a lot of yellow highlighting on this article. So I'm thinking about just cutting out a lot of the fat and listing the 10 key questions that Medicare Advantage plans are facing right now. So question number 1, how long will hospitals put up with denied payments? Medicare Advantage plans will require that a hospital or a doctor ask their permission before they're promised to be reimbursed for a medical procedure for a client or a patient. And if the company decides not to approve the payment for that procedure, that's called a denial. And they're going to deny payment for medical treatment for a member of that plan. And that has happened so frequently that hospitals are now having to face that as a budget buster item. And in many cases that I've heard of over the last few months, these hospitals have stopped doing business with Medicare Advantage plans. And I think that's, so far that's a growing trend. So we've learned about Scripps in San Diego, 30,000 people. None of those people are going to be allowed to remain Scripps patients if they're covered by Medicare Advantage plans. Same thing with the Mayo Clinic in Jacksonville, Florida. They will not accept patients who are covered by Medicare Advantage plans. And I believe that's also true of the Mayo Clinic in Arizona. I don't know for sure about the one in Minnesota. And there are some other major facilities that have stopped accepting Medicare Advantage plans from their patients that need treatment. So is that going to spread? Is that going to cause problems? Question number 1, how long will hospitals put up with denied payments? Question number 2, what other options do hospitals have? Well, they have Medicare and they have Medicaid. And I think those are the only other options. Now, self-pay would have been a good reason in many respects, but then I ran into two clients of mine who were patients in Florida of hospitals, and they were not accepted for treatment because self-pay wasn't good enough. Both of these people had Medicare, which pays a large chunk of your outpatient expenses and a large chunk of your inpatient expenses, but that wasn't good enough for these medical facilities. Medicare itself was not good enough. The fact that they did not have Medicare Advantage plans, Medicare supplement plans to pick up the slack, what made them persona non grata in those hospitals when they went for treatment. So it is important that you consider the fact that a doctor or hospital may not want to treat you if you don't have any kind of insurance beyond traditional Medicare, which pays the bulk of your expenses. Question number 3, what is the future of prior authorization? That is the process by which a Medicare Advantage plan is able to deny or delay the payment of a procedure for one of their insured clients. So we don't know what the future is. That's one of the burning questions that the Medicare Advantage people have to work out. How will the 2 midnight rule shake up hospitals' relationship with Medicare Advantage? 2 midnights means if you are admitted to a hospital and you don't stay 2 midnights, two full days, basically, then you could be considered to never have been actually admitted, that you were only under observation. And that could change the way that you are allowed to get treatment beyond the hospital stay in a nursing home or a recovery facility, because your definition for Medicare gives you the right to be paid or to be reimbursed for a nursing home stay or a rehabilitation stay if you were in the hospital for 3 full days prior to that stay. Otherwise, you're going to be aced out of the benefit that you expected to rely on after whatever surgery or procedure you had. You will not be able to be reimbursed for a recovery or recuperation stay in a nursing home or a facility of that type once your hospitalization is over, because the assumption will be that you were not really an inpatient at the hospital. Number 5 question that Medicare Advantage plans have to face: has Medicare Advantage lost its luster for insurers? And this seems like a fun, I could read the meat behind this question. While hospitals' frustrations with Medicare Advantage grow, insurers are facing another set of challenges in the program, which no longer promises the same level of profitability as it once did for for-profit insurance. In January of 2024, Moody's analysts wrote that the program seems to be losing some of its luster. According to Moody's, earnings in Medicare Advantage shrunk by 2.1%, which doesn't sound like a lot, but it's a lot of dollars. It's a fairly big stack of dead presidents. It shrunk 2.1% from 2019 to 2022, despite premiums and membership growing by 40% in the same time period. Question number 6, will Medicare Advantage benefits be cut back? I can almost guarantee you that when I put my ear to the ground, that's the noise I'm hearing, that their freebies that they've been touting as valuable additional benefits for so long are not going to stay as generous as they have been. And in fact, I've seen evidence that they're going to be lying about it. So they're not going to say, well, we are cutting back our dental benefits. They're going to be skimpier than they used to be. They're going to say, don't worry, sign up with our plan. We still have dental coverage. But if you delve into the fine print, you're going to find that the dental coverage that they have now is not nearly as generous as the dental coverage they were purporting to offer to their members a couple of years ago. And that's one of the ways that they're going to try to stay afloat, is to cut back on some of the freebie benefits that they say that they're offering to their clientele. Question 7, are supplemental benefits working? Well, virtually all Medicare Advantage plans offer hearing, vision, and dental benefits, coverage not included in traditional Medicare. Many offer over-the-counter drug benefits, meal support, reduced cost sharing compared to traditional Medicare plans. While the offering of such benefits is widespread, utilization of them is less clear. The government lacks data on how often supplemental benefits are used in the program, but according to a 2023 report, they are not used as frequently as they have been in the past. So there's a new regulation that in, I think, either 2024 or 2025 that will force Medicare Advantage insurance companies to send a report to every policyholder telling them about the benefits that they may not have used. And I think identifying which ones they should be using and recommending that they start using them. Now, the government's forcing the insurance companies to do that. They're not doing it through altruism at all. So, with that, I say we should probably take a little break and see if there are any sponsors that are willing to step in and say to pitch their wares. And I'll be right back after we find out. All righty. I can't wait to listen to this back and see if any sponsors stepped in, because that means more Christmas party money for the Medicare for the Lazy Man staff. And that's what we're all looking for, is a big fat stack of dead presidents to spend on our Christmas celebration. Okay, question number 8. Can the government curb overpayments? The government spends more on Medicare Advantage beneficiaries than comparable employees in regular Medicare. Two factors account for this disparity, according to the government, according to MedPAC, which advises the U.S. government on Medicare. The first is favorable selection. Medicare beneficiaries, Medicare people who enroll in regular Medicare, tend to use fewer services, and they tend to self-select into Medicare Advantage plans. Well, this is a upside down and backward sentence. The second factor driving disparities is coding intensity. Medicare Advantage plans are paid based on beneficiaries' risk. So plans are incentivized to document more diagnoses in patients' records. Yeah, that's what they do. Medicare Advantage plan from an insurance company will tell an agent, a sales agent, we're going to pay you a very hefty commission, $600 for the first client that you enroll, $600 for each other subsequent client that you enroll. But then we're going to send you back out with a questionnaire. And you've got to go to those clients and fill out the questionnaire asking about their medical history. And they're going to hope that there is indication of more medical problems than they really anticipated. Then the questionnaires are sent to the government, which will then tell the insurance company, okay, we didn't know that these people were sicker than average. We're going to pay you even more money for each person you have with these various serious illnesses and conditions. So that's how they increase their take from the federal government. Oh, and that $600 commission for the agent, well, that's going to keep them coming back with more clients and more clients and more clients. I've heard of agents doing some very underhanded things to acquire clients in the Medicare Advantage realm. And in fact, the government has heard a lot of complaints. We've seen the commercials that are proliferant during the open enrollment part of the year. But those people, the government's trying to crack down on them, but they're doing it in such a heavy-handed way that nobody is going to really have their situation improved. But that's the way the feds do things. They do them in an untoward manner that just doesn't make any sense. They're penalizing the good agents as well as the bad agents. They ought to be just separating out the bad agents that perform the disservices to their clientele and yank their licenses and send them off to do some other kind of work. That's what should be happening. Does Medicare Advantage deliver better outcomes? So Medicare Advantage has yet to deliver on yield savings for the government, and the evidence is inconclusive as to whether the Medicare Advantage program is tied to superior outcomes and care. Traditional Medicare enrollees with a supplemental coverage, with a Medicare supplement, were the least likely to report cost-related problems. So once again, as I say, if you have a Medicare supplement along with your regular Medicare Parts A and B, you're going to be least likely to be disappointed or to have problems than if you have a Medicare Advantage plan. So the question is, what's the future of traditional Medicare? And frankly, my content curator did not highlight any of the subsequent explanatory paragraphs after that question. So I think the question stands and it will not be answered today. What is the future of traditional Medicare? Well, it's going to take an act of Congress to change it. I'm hoping that it has not changed in a way that makes it more difficult for the Medicare enrollees and my clients, that they have that they're able to continue on using a system that is full of promises and they deliver on most of the promises they make. I don't want to see Medicare go anywhere, but if it is changed in a significant way, then I'm going to say that I would like to see it privatized with the same protections and promises, guarantees that people currently have. I don't know how that would look, but I don't like the model that Medicare Advantage gives us because it offers too many opportunities for the insurance company to rip off, deny, and delay coverage of their clients. So that's not the answer that I'm looking for. I ran across an article that was sent to me by a relatively new client of mine a while back, and I've been sitting on this for quite some time. And I'm going to try to do a synopsis of it because this guy is pretty interesting. His name is Dean. He's a relatively new client, and he listens. He's an avid podcast listener and Medicare for the Lazy Man book reader. So his message to me is, "Hey, Doug, I listened to podcast number 621 today. That was 40 podcasts ago. Thank you for the honorary mention again. I like the back and forth that you and Randy do. Tell Randy he always has plenty of pithy comments. He just doesn't know what the word pithy means." And then he did a little smile thing. So he's gently prodding Randy. And I guess I'm sure Randy is able to rise to the occasion if any reverse prodding is going to happen. So he quotes Randy as saying today in that particular episode, he said that I put him on the spot. Well, in any event, Dean has a history of living in Panama, or at least he worked for the federal government, the Department of Defense, for a long time. And he has become very familiar with the country of Panama and their health care system. He said in Panama, he was traveling in a well-known expat area named Boquete is the way he did the pronunciation. It's an idyllic part of Panama it's in the high mountains, year-round temperature 72 degrees. Anyway, he met a lady approximately 75 years old. She told Dean that she had to return to Georgia for her cancer treatment. Dean said to her, "It's a long way back to Georgia. Why don't you get treatment here?" She said, "I don't have any insurance that will cover it." I didn't get any further details, said Dean, but I thought she must have Medicare Advantage versus Medicare Supplement. Now, here's where Dean misunderstood one thing that I put in the book. A few of the Medicare Supplement plans offer coverage outside of the United States, but it's only coverage for emergency treatment, not coverage for routine or ongoing treatment of medical conditions. So Dean did not understand that when he wrote this message. He thought that Medicare Supplement plans covered you no matter where in the world you are. I've since disabused him of that notion. Anyway, Dean goes on to say, Panama has some of the best health care at 1/3 the cost of the United States. It doesn't cost much to buy private health insurance there. Full coverage for a 70-year-old would be about $400 a month. Now, I got to say, if that's $400 US, full Medicare coverage in the United States is less than that, and much less than that if you follow my recommendations to get the high deductible or high value Plan G. In any event, he says many Canadians and Western Europeans are astounded at the great health care, immediacy of getting care, which is a very important thing, and the low cost, even if you're paying out of pocket. Let's see here. So he enclosed an article saying the healthcare system in Panama and your health insurance options. First, let's discuss the system in Panama. Panama does not have universal health care, at least not for people, and not part of its working economy. The author says, I'll explain this in detail later on. Panama has a two-tiered healthcare system with public hospitals called regional hospitals, with public clinics called polyclinics, and Social Security hospitals. And it has a private hospital system with private clinics, doctors' offices, and labs. They are both pay for service systems. Fee for service is another way to put that, with the public systems being much cheaper. If you're an employee or a business owner in Panama paying into the Social Security Fund, you can use the Social Security system for free. Panamanian retirees receiving Social Security also have access to this healthcare system. Suppose you, as an expat, come to Panama on a visa like the Friendly Nations visa or an employment visa. In that case, you may also have free access to this healthcare in Panama if you pay into Social Security. Anyone can use the public system and pay for it. The way this Social Security system is funded is through paychecks. The employer deducts a certain percentage from the employee's pay or their compensation. There's a percentage match contribution from the employer. And that's always bogus because that just comes out of money that could have been paid to the employee. And the employer submits that money to the Social Security office every month, similar to payroll deductions in other countries. Those not covered by Social Security, like contract workers, self-employed, who opt not to join the program, tourists and expats living here, not employed, can use the public healthcare system on a pay-for-service method. The costs are very inexpensive, like $5 doctor visits, $5 specialist visits, and $5 physiotherapy sessions. An incident like a broken bone, including visits, x-rays, casting, care, and cast removal, can cost as little as $50 for the entire ordeal. If you do not have the $50, you can arrange with the hospital for monthly payments. There are some problems with this system, including long wait times, old buildings, and equipment, no private rooms if you're hospitalized, lack of doctors in specific fields, lack of some prescription drugs, and just maybe not the experience someone from North America or Europe could handle or get used to. So anyway, this article goes on to describe the Panamanian healthcare, its two-tiered system, and how it can be used to your advantage, and it's very inexpensive for those who live there. And I'm not going to read all of this because if you're that interested, you can Google and find this article yourself. It's entitled "The Healthcare System in Panama and Your Health Insurance Options." So Dean would encourage you to read that because it's for him and for other expats. My brother was an expat to Hong Kong. That's where he enjoyed living most of his final years. Expats have trouble finding places that are suitable to live, I guess, and Panama appears to be one that is very expat friendly. So with that, I think I want to hang it up for today. If you don't mind, Randy, I'm going to go take a warm bath and then contemplate my navel.
That sounds like a good time.
Yeah.
So I got to tell you, the 75-cent clock is done.
I heard the ding.
Yeah. I'm going to have to do a real quick close up here before we go, because I always do. It's my responsibility as the highly paid producer of Medicare for the Lazy Man podcast. Otherwise, I wouldn't be
as the producer who gets to live in the luxurious company-owned property.
That's right. That's the reason I can afford all these, Airbnbs and, the buildings that we own. But unfortunately, we haven't been able to work it out so Doug can see any of these.
I'm waiting for a tour.
We're going to get one together one of these days. So everybody with a pencil, I want you to scratch down this email address because you need to reach out to Doug. If you have any questions or comments, you can do that at dbj@mlmmailbag.com. Do not forget, Doug is licensed nationwide to help you with your Medicare supplement planning. Check us out at the website, www.medicareforthelazyman.com. in your wanderings through the wilds of the internet, if you can find a place to drop a couple reviews on the content that we provide, it would be awesome. The numbers are worth a lot to us, as you might imagine. Number 4, certainly not last but not least, thank you for joining us today. You could have been anywhere else in the world doing pretty much anything else, but you weren't. You chose to spend a few valuable moments with us, Medicare for the Lazy Man podcast, and I can pretty well guarantee you that you were either looking out the window watching for the army of cicadas to come, and if you were, you weren't checking your wristwatch. But if you would have found that you have just spent about 32 and a half minutes with Doug Jones, the anti-insurance insurance guy, originally from Oklahoma. No more today and for the foreseeable future this summer. He's camped out, and I was going to say the high ground, but it's not high.
No,
He's
it's
about
not.
732 feet above sea level in his fortress of solitude. We're going to call it his smaller, petite fortress of solitude in Illinois. So anyway, I'm going to turn it back over to Doug so he can wrap this up. And I want you guys to all have a good day.
Thank you, Randy. And thank you, ladies and gentlemen. It's always a pleasure spending this time with you. And I'm looking forward to our next opportunity at the next episode. So come on back here. Bye-bye.